1. We are live now.
Greetings, everyone. Some of you will be in the different time zones. I'm Dr. Wu Pang Hong from Singapore. I practice in Mount Elizabeth Hospital. It's my honor to be the MC today on behalf of Dr. Vishal, who is currently in the midst of a business. Today, we will be having our second advanced spine webinar. The main topic is on endoscopic spine surgery. We will be having our honor to have our APSS Secretary, Dr. Gabriel, to give us the welcome address. Thank you, Professor Gabriel, who is Chief of Spine in NUHS.
Thank you very much, Bang Hong. And then my name is Gabriel Liu, and then I'm from Singapore, and I'm currently serving in the APSS as the Honorary Secretary. On behalf of our President, Professor Kwang, current APSS President, we'd like to welcome you all to this wonderful second webinar for the APSS. As you know, APSS is the Asian Pacific Spine Society, which made up of 19 chapters of the country and various different fractions of the spine society to join together. We aim to promote spine research and the best practice, and the most important is fellowship among one another. So based on this principle, the webinar, since the inception from 2021 by Dr. Vishal, and then we have been ongoing in the last 3 years. And in this year, this is the second webinar as Dr. Wu Bang Hong talks about it. And it's now each webinar is focusing on a specific theme, and this one is focusing on the endoscopic. There will be one focusing on cervical spine, working together with CSRS AP China chapter, and there will be one focusing on the lateral access surgery and many more to come. So please do look out for all this. In addition to the webinar, I would like to highlight to the participant, we do actually also have life surgery courses, as well as many of the basic spine courses and traveling fellowship for you to participate. So do join us as a member. And then we're all looking forward to seeing you all. And most important is on behalf of Professor Kwang, invite you to the annual meeting, which is going to be in Kuala Lumpur next year in June. So we're looking forward to you all to participate. So without further ado, I wish you all well. And I want to thank all the wonderful faculty who has been here. And then I will let Dr. Wu to continue to introduce them to you, and wishing you have a wonderful webinar session and a fruitful evening. Thank you very much. Back to you, Bang Hong.
Thank you for Professor Gabriel Liu. Indeed, it is wonderful that APSS can give us space to discuss various parts of spine surgery. And today we will be talking mainly on endoscopic spine surgery. First, we will have Professor Kwan Sup Song, who will be showing us his personal perspective on biportal endoscopic spine surgery, followed by Dr. Cheapon, who will be talking about endoscopic treatment in lumbar spondylolysis with or without spondylolisthesis. Subsequently, Professor Xu will be talking about selective application of UBE technique in cervical spinal conditions. And Dr. Rajeesh George will be talking about incidental dural tear and UBE causes management and prevention. And Dr. Nantawat Uttamo will be talking about UBE in decompression foraminotomy. And finally, Dr. Harman will be talking about biportal endoscopic spine surgery in Bertolotti syndrome. It's a very comprehensive program. It covers from cervical to a large aspect of lumbar surgery. Without further ado, let's invite our first speaker, Dr. Kwan Sup Song, who will be talking about his personal perspective on biportal endoscopic spine surgery. Dr. Song, please.
Yeah, it's a great honor to be here for a second advanced spine webinar hosted by APSS. My talk is about the bipolar endoscope spine surgery. My personal standpoint for endoscope surgery is here. So my first surgical experience began in 2006. bipolars in 2019. However, as you can see, there has not been many cases considering this time period. One of the reasons for this seems to be that I have personally grappled with some consideration about its efficacy and value, both for patient and surgeon. The term UBE has been widely used and categorized into endoscope-assisted surgery. However, the term BAS, bipolar endoscope spine surgery, has been also in circulation for quite a long time in Korea as well as other countries. In my personal opinion, BAS actually is more fitting term than UBE, as a better contrast with the unipolar and full endoscope surgery. In definition of MISS, it should demonstrate the better clinical outcome compared to traditional method. I strongly agree with the graphs on the right side about endoscope benefit zone. It is believed that decompression surgery with a higher surgical complexity is more useful than a simple one. That this benefit zone has recently expanded to include the arthrodesis. Let's just think about the advantage of bipolar versus unipolars. First, all you need is an arthroscope system and conventional spinal instrument in starting bipolar. You don't need to invest heavily in your specialized equipment. I commonly use a 30-degree scope and a natural drainage system because patients with headache issues initially. Making the polar is very crucial. Instead of following some strict rule, I usually create two polars about 2 or within 4 centimeters apart to the center of the target entry points. If you create a working space on the bony structures called base camp, so you can go everywhere. Also, it is important to broadly create a working space. I mainly use the cups, as you can see. And when you insert the scope, after organizing the surrounding soft tissue well, then you can easily see the create space on base camp and facilitate rapid surgical progression. Closer look over merit of a 30-degree scope. First of all, if we can get some working space just above bony surface and through, we can get a wider surgical view and more complex surgery is possible. Finally, we can get a wider surgical indication. When initially use a 30-degree scope, we should have attention to potential misorientation, particularly in depth distortion. Maintaining proper orientation to the midline is essential. Failure to do so can result in facet violation as illustrated in this image. Also, we can create an additional polar and put the two instruments through the single polar. When retracting root, we can insert the instrument lateral side of it. So personally, several big advantage of bipolar compared to unipolars are that it allows for easy start as it does not require specific equipment and has a less steep learning curve. Additionally, provide a wider view with the 30-degree scope or additional polars. Ultimately, it is thought that bipolar shares the same indication as microscope spine surgery. However, we should be mindful of this potential issue of bipolars. A critical point that cannot be overstressed is maintaining adequate outflow to prevent excessive hydrostatic pressure in the working space. Additionally, we have to keep in mind for potential thermal injury when using the radio frequency and the challenging in detecting and suturing duration. Let's just see some case. 45 females, the status post discectomy at the left side, and as you can see, the severe bilateral large extruded disc and bilateral symptoms. And if so, this is right side. We'll remove the right side extruded disc. If we use 30-degree scope, you can see the cleft is located in the center. And as you can see, remove the contralateral side disc, such like this. This is post-op showed, as you can see, the well remove the extruded disc contralateral side. In my experience, unilateral laminotomy for bilateral decompression represent the most suitable indication for BAS using 30-degree scope. When you are going to the contralateral space, as you know, securing space at the base of lamina is very important. Sometimes if you use the curved osteotome like this, you can get a decompression of a contralateral root with the minimal laminotomy. You can see the ipsilateral transverse root and the contralateral root. Sometimes we needed to 3-root exploration. This patient showed a bilateral spinal stenosis in spinal canal, and the right side foraminal stenosis and with the spondral recesses. So as you can see, the contralateral transverse root. If we rotating the camera, so you can see the contralateral exiting the root and the ipsilateral root. As you can see, the so well decompressed nerve root. The extraforaminal decompression can also be an excellent indication for bipolar surgery. There are some caution for bleeding for the facet artery branch, but it can be effectively controlled. This is the isthmus area, so we remove some soft tissue, and we can see the pulsating nerve root. And we can confirm some full decompression beyond the pedicle. This case is a bipolar Tully case. 67 female, she got extraforaminal decompression 3 years ago. MRI showed a severe foraminal stenosis and some adhesions. Recently, I tried to ambulatory resection of inferior articular process if possible. So after removal, so widest working space can be obtained immediately. So, and also it may be very dependent on the region. The insertion of the cage with a large footprint could be easy if the exiting route is confirmed. This is a post-operative 1-year radiographs that show the well-sustained intervertebral space and the well-decompressed nerve root. In summary, bipolar endoscope surgery in decompression case, easy to start, can be opened at every spine surgeons. I think is a comparable outcome and efficacy. I believe they provide some advantage, especially in some more complex cases. However, some special caution is advised for cervical and thoracic myelopathic case who require the extensive centripetal decompression. Bipolar fusions is getting popular and wider indications, but there are still controversy for better outcome and fusion rate compared to the minimal invasive Tully case. So we should be open to cutting edge trend. However, being the first is not matter. The crucial question is likely, why is the necessary? The answer for this should be obtained from data and knowledge, and if you are fortunate, senior wisdom. After getting answers, we should address the question, can I do it better than current techniques? How about best for me? So I would say it does work to some extent. Thank you very much.
Thank you, Professor Kwan Sap Song. It's wonderful insights to bipolar endoscopic surgery. Is there any questions from the floor? And have a few minutes for questions.
I'm sorry for some there were some mismatching the narration between the narration and the video.
Okay, so Professor Song, since there are no question from others, I would like to ask you a question. In your journey of bipolar endoscopic surgery, what you felt is the most difficult learning curve in your initial period?
Yeah, so thank you for a good question. So in a unipolar experience, I suffered from some very limited indication. So using unipolar techniques. So when I met the bipolar surgery, we can extend the kinds of indications of, but I think some bipolar could be good options and provide us some less stiff learning curve. So when you are some experienced spine surgeon at the so now I'm try to do the bipolar surgery, but I think some myelopathy case and a multi-level fusion case. I'm trying to that kinds of case, but I think I still consider some benefit, John, of this kinds of surgery.
Dr. Srivastava asked whether there's any specific reason where you had to convert it into an open procedure.
So in my first experience, so dural tear is a common case to convert to open case, but I think two cases maybe and one case is some bleeding, so one of the cause of some to convert to open cases. But if you have some experience with more 20 or 40 cases bipolar, so if you're experienced surgeon, you can overcome that kinds of limitations.
Thank you.
Thank you. Hello, Professor Song. I'm Nantawat from Thailand. I have some questions for you. And in your opinion, for the surgeon who want to start the UBE, do you have suggest the kind of the case that good for the start for the UBE? Like the case the SNP or case the stenosis. What case do you think is should be start first?
In my experience, stenosis case is more easier to me because there are no handling of the some neural tissue, but discectomy case could be easy. So, but I think, but in my series, in first series as the bipolar showed some higher recur rate in initial phase, but you have to pay attention to about the recur case compared to the conventional case. So everything will be okay. So if you are experienced surgeon, you can use the bipolar in any kinds of decompression case. In a fusion case, I think we have to experience some decompression decompression case. So, and then after that, you can do some fusions.
Okay, thank you.
Thank you.
Okay, thank you, Dr. Song. So now we will proceed to the second talk today. Will be by Dr. Chayapon Suramanakul. His topic is on endoscopic treatment in lumbar spondylolysis with or without spondylolisthesis and the role of repair. Thank you, Dr. Chayapon.
Thank you very much. Hello, everyone. I'm Dr. Chayapon Suramanakul. I would like to talk about role of endoscopic treatment in lumbar spondylolysis, decompression, repair, and fusion on behalf of Professor Pornpavit Sriphirom from Phayyathai Pahonyotin Hospital, Bangkok, Thailand. The spondylolysis is anatomical defect of the vertebral arch or a fracture of the pars interarticularis that can make the vertebral slippage, as we know spondylolisthesis. Regarding pathoanatomy of the nerve root compression in L5 spondylolysis, the exiting nerve root is trapped by the hook-like remnant of the deficient lamina up to the base of the L5 pedicle. And it is increasingly compromised by escalating degree of the slippage. The L5 nerve root could be compressed by annular bulging of the edge of the lower vertebra anteriorly, and the bony hook posteriorly. According to the full endoscopic decompression in spondylolysis, Anthony Yang has been used transfemoral endoscopic decompression in stable ischemic spondylolisthesis and got the good result. In the other hand, our experience has been performed transfemoral approach for discectomy and for foraminoplasty in the young patient with extrafemoral disc herniation combination with L5S1 spondylolisthesis. After follow-up for 1 year, we found the patient developed further vertebral slip. The reason is the iliolumbar ligament has played the important role for preventing anterior displacement of the L5 vertebra. According to the cadaveric study, the iliolumbar ligament formed during childhood and adolescence by metaplasia and muscle fibers and fully developed at 40 years. Therefore, using transfemoral approach in patients younger than 40-year-olds should be careful or avoid to prevent the iliolumbar ligament injury. Decompression alone. Regarding interlaminar pars decompression in L5 spondylolysis or L5S1 spondylolisthesis, the entry point is not L5S1 interlaminar window, but should be L45 interlaminar window that easier to find the par. In this case is a 56-year-old woman represented with L5 radiculopathy. MRI show pars defect at L5 and the L5 exiting root compression. After introduce the scope, the first thing we
Sir,
should
I'm so sorry to
identify
interrupt, but the volume is very
the
low.
L45 facet joint, and then move
Sorry about that, maybe from my
a
video.
little bit cautery. You will find the part defect. After we find the part defect, we should remove the soft tissue in the parts and remove the fibrocartilaginous mass by using the high-speed burr. Is more easier. After we remove the soft tissue in the part, we will find the L5 exiting nerve root beneath and then perform decompression to free the L5 exiting nerve root. After the pars decompression, you will see MRI show the epidural fat in alpha S1 foramen very clearly, comparing with before surgery. Spondylolysis in the young. This case, 17-year-old female, presented with low back pain and failed conservative treatment for 6 months. MRI show part defect as alpha S1 level. And the CT scan confirmed the part defect as well. In this case, we perform endoscopic decompression and bone graft combination with percutaneous box screw. Spondylolysis in patient less than 40 years old or back pain or spinal instability. In patients with spinal instability or back pain, we recommend to do full endoscopic decompression and percutaneous screw fixation and endolift. The first step, we insert the percutaneous screw after the screw insertion, and then we perform endoscopic pars decompression. And the last step, we insert the peak to perform the endolift. In this case, 52 years old male presented with bilateral buttock pain, right more than left, and the pain aggravated by back extension and walking. The radiograph show part defect at L5 and L5S1 spondylolisthesis. The motion film found spinal instability in this case. MRI show part defect at L5S1 and the nerve root compression. In this case, we perform percutaneous screw fixation and endolift. After operation, the back pain and the buttock pain improve from before surgery and no motor weakness after surgery. For the conclusions, role of endoscopic treatment for spondylolysis with or without spondylolisthesis. If the patient presented with back pain or spinal instability. In young patients, we recommend endoscopic direct pars repair with back screw. And the patient less than 40 years old should be performed full endoscopic decompression combination with endolift. If the patient presents with radiculopathy from the nerve root compression alone, the endoscopic pars decompression alone should be performed. Thank you very much for your attention.
Thank you, Dr. Chapon.
Yes.
So while waiting for some question, I have a question. For those who have radiculopathy and you perform decompression alone, first question is if they have bilateral radiculopathy, do you still do that or you do fusion? Second question is how many of these cases you find there is subsequently some instability back pain that which you require some treatment?
Yes, the first question, if the patient have instability, bilateral radiculopathy, I will perform the bilateral pars decompression. If the patient have no symptom of the back pain or the spinal instability, I do not feel. And the second question, could you please ask me again? The second question.
So after we do pars decompression, are there cases where patients have more back pain, although the leg pain is relieved, more back pain? And what is your treatment options?
Yeah, okay. My principle for spondylolysis, if the patient have back pain or spinal instability, I will perform endolift fusion and combination with the decompression.
Okay, so in your series, when you do pars decompression, are there cases where they become unstable? Because it's what most of us are worried when we do decompression or pars alone without fusion.
Yes, actually, I have studied that published last year about decompression alone. We found that only around 1% that have a further slip of the vertebra after decompression alone.
Oh, 1%. Okay, that's very low. So what you think is the holding the bones together since there's no pars? You think the disc enough and and the posterior ligamentous complex is enough to hold the spine together?
Yes. After I study about the further slip after decompression, we found that the important role is iliolumbar ligament that are connected between L5 transverse process and the sacrum. Some cases, we more decompression and injury to the iliolumbar ligament, especially in the transverse process, that make the patient have a more further slip.
Okay, thank you, Dr. Chapong.
Can I have a question, sir?
Yes.
Yeah, sure, question. So thank you for your nice lecture. So you demonstrate the endothelip case in the last part in your presentation. You do the bilateral decompression pars area using endoscope and some interbody fusion, is right?
Actually, I do decompression on the at the side, symptomatic symptom.
Okay. So
yeah,
some surgeons believe that in the kinds of case, total laminectomy should be performed because when you cut the inferior articular process, some floating, some the lamina, and it could be of some impingement of pus area. So how did you about this, about the total laminectomy in such like a patient?
I actually in spondylolysis with instability, I never done total laminectomy.
Oh, really?
I done only the prior decompression and dissect the symptom sign, the facet and do the fusion.
Okay, thank you.
Okay, in that case, there's no further question. We can. Dr. Shi is still not here. He's involved in an operation, so we'll be having Dr. Rajeesh George will be talking about management of dura tears. Dr. Rajeesh, please. So in the coming sessions by Dr. Rajeesh, Dr. Nantawat, and Dr. Harman will be presenting some cases. Then we have some discussion on management. Then the speaker will show us how they manage the case.
Very good afternoon. Can you all see my slides?
Yes, Dr. Rajeesh.
Okay, thank you. Hi, hello everyone. Very happy to be here. I'm very honored and I thank the APSS committee for inviting me to give this talk. My name is Dr. Rajeesh George. I'm a practicing orthopedic surgeon in NUHS in the Kwang General Hospital. So today I will be talking about dural tear in UBE. So first I'll present one of my cases which had a dural tear. So this is the hospital campus that I work in. It's called Kwang General Hospital. It's part of the NUHS campus, and we cater to the west of population of Singapore. So, so starting with the case, so this is a 57-year-old Malay female who came to see me, and she was having 6 months history of a bilateral posterior thigh and gluteal claudication, and she could hardly walk less than 100 meters. There was no other symptoms. There was no back pain. The significant past history was she had a TLIF, open TLIF, which was done at lumbar 4, lumbar 5. This was almost 10 years ago. And she was asymptomatic till 6 months ago when she had this bilateral thigh pain. So I did an X-ray, actually showed there was a good fusion at 4-5 level. But the facet joint at 3-4 was showing facetal arthropathy. So I did suspect there was adjacent segment degeneration and stenosis. So I went ahead and did the MRI, which confirmed there was a 3-4 adjacent segment degeneration. There was a significant central as well as a lateral recess stenosis. However, the foramen was okay. So I did counsel her for various options, including conservative. Surgical was an extension of fusion to 3-4 or a UBE decompression. And since she didn't have any back pain, she opted for a UBE decompression, and that is what I did. So I did interlaminar 3-4, a UBE decompression standing on the left side. And I'm just going to go to the video. And since our topic is dural tear, I'll just go to the video here where I will show you what actually happened. So this, I'm starting in the middle of the surgery. So here I have actually separated the flavum from the ipsilateral side, which is the left side. And here's the picture, which actually shows there is adhesion between the dura as well as the flavum. And this was supposed to be the virgin side, and apparently there were adhesions there as well. So here I'm trying to separate it from the flavum with the help of pen field, and it was quite stuck down. So I tried got a closer look. I saw there was a firm adhesion there. So I tried to separate it, and I couldn't separate it from the ventral aspect. So I went dorsally. And so here you can see I have separated the flavum from the cranial lamina, which is L3. And the adhesion actually is visible from the dorsal aspect as well. So try to separate it again with a pen feel, try to create a plane. It was quite firmly adherent. So couldn't really do much from the dorsal aspect. So then I went back to the ventral aspect there, and then again try to create a plane. In between, I used some nerve hook, which I still couldn't separate, and so then I tried to create this plane, and this is the exact moment where the dural tear happened. I didn't realize it because it was actually partly covered by the dura, and so when I lifted the flavum up and removed the pen field, and I saw, and then that's where the dural tear was. It was actually more than a 1 centimeter linear dural tear on the ipsilateral side on the dorsolateral aspect. So that's my first part of the presentation. I hand over to Pang Hong to see whether want to have a discussion first, and then I'll go to what was done.
Okay, you can. So this discussion involves all our speakers. So Dr. Chayapon, you do uniportal. So this is a biportal, I know. What will you be able to? What will you do if you see such a case in uniportal surgery?
Yeah, thank you very much. Very good question. Actually, in the incidental neurotomy, I consider the size of the tear. If less than 1 centimeter, I doing the patch blocking dural repair. But in this case, the tear size is 1 centimeter. I would direct repair via endoscope first.
Okay.
And yes.
How will you repair it? You suture it with your uniportal scope?
Yes. But actually, it's quite difficult. But if you practice, you can do that.
I see. How do you tie the knots after you retrieve your needle?
Yes. We use the knot pusher from the sport medicine in the ACL, PCL, something. Yes.
So they are long enough to push through a uniportal scope.
Yes.
Okay. Okay. Thank you, Dr. Chayapon. How about the rest of the speakers? This 1 cm. What will you all do? Starting from Dr. Song, maybe Dr. Song, then Haman and Nantawat. Yeah.
I think sometimes I leave it. Sometimes I commonly use some vascular clip, small vascular clips. Some I try to some approximation about some tear areas. It's not a perfect suture. So and I put the taco comb suture, I think. So I have several cases of dural tear in bipolar surgery. I think so. I have no experience about of serious complications. Sometimes so it is very helpful to some approximation using some vascular clip. I think, yeah.
If the nerve root comes pretty close to keep coming out of the dural tear, what will you do before you put your first clip?
Oops. So at that time, some extruded some root there. So I think some conversion to open is more beneficial.
Okay. about Haman, Nantawat, and Professor Liu? Any comments?
Yes, Bang. Can you hear me?
Yes, yes.
Yeah, so for dural tear incident, if I don't see any rootlet herniation, I would leave it alone. But if you see a rootlet herniation, you can suture it by, I think it's easier to use by portal surgery compared to uniportal surgery. If you use by portal surgery, as Professor Song, I would like to use a vascular clip. But the problem is to make the tear close enough to clip the vascular clip. So before I push the rootlet herniation using a petish, I insert the petish inside the dura. And then sometimes I do another portal just in between for my assistant to grab the dura. It's easier to clip with the vascular clip if your assistant can carry your dura out. That's what I do.
That's a good trick. How about Dr. Nantawat?
Yes. For me, I think it's same as another. For me, I think it's up to the size of the dura tear and the character. If I think if the dura tear is just like a linear tear and no nerve root come out, I think just a patch with a gel foam or taco seal is enough. But I think it's in like a laceration tear, and I think we need to suture it to repair it with the suture. And before I do the suture, I usually put the gel foam inside and suture. Yeah, put the gel foam and approximate the edge of the dura and suture. Yeah. But if I try and the dura edge not approximately properly, I think we need to turn to the open surgery, open repair in the severe case. Dura.
Actually, just a comment from my side. I think sometimes I see this adhesion, the adjacent segment, and they do have adhesion on top and below, L34, L5S1. And if the flavum is really stuck, I actually just make an island out of it and leave it alone. It's like a patch blocking repair with the flavum, but it's a flavum on the dura. If they are not attached to anything, I think generally most of the compression come from lateral recess, so it should be okay. Just go look for the disc and look for the axillary fat. Once those are identified, if there's really a flavum stuck, they're usually stuck in the middle. They never really get stuck at the pedicle or the exiting nerve root area, usually in the dorsum, quite close to the epidural ligament, I think. So I usually left that alone. So no need to try too hard, maybe. So I don't often. In my early stages, I have some of these tear. After that, I think I get a little bit less brave over the years. I just make it an island after, and I find that they are okay in terms of stenosis decompression. What you all think? Any of the speaker?
So you mean you just keep the flavum floating?
Those that part that is stuck, you just trim until it's really small, and then if it's really stuck, just let it be stuck. Then I mean,
yeah. I agree with Dr. Wu.
Yeah. The important case is the lateral recess. I think that's the most important part to decompress in the spinal stenosis.
Yeah. And I think the trick for the revision case, we need to check the pedicle first for me. Because if we know the pedicle, the medial pedicle, actually medial to the medial pedicle is a root that we can identify the nerve root and the edge of the dura easily.
Yeah. Okay, then Dr. Rajeesh, maybe you show us what you have done.
Sure. All great points. Thanks all. I'll just go to my see what was done. Okay, so anyway, it was probably a good idea to leave it alone. Anyway, I had caused a dural tear, so then I had to do something about it. So my plan was to assess the size. I'm just going to play the video. Sorry, this assess the size. I usually use a nerve hook to assess this. So here you can see that I have cleared the edges of the tear, and there's a reasonable hemostasis. I have dropped the pressure of the water, and then assess the size and the location and define the edges. And here I used a little different method. So here what I did was I used a tacosil and I cut into 1 by 1 centimeter patch. And this was, so you can see that when you introduce a patch inside with a pituitary fossa, usually it gets stuck. So I use the portal to hold it in. And then I did an inlay or a patch with that tacosil. And so I kind of push it inside. There were no nerve rootlets coming in, but I still had to do a little bit of decompression. So I had to address a dural tear at a bit early compared to what it was. So I pushed that tacosil inside like a inlay patch. So here I'm using the pen field to push into underneath all the sides of the dura. And so here the dura is kind of sealed. And then I did my decompression. Again, I assessed the size. And then I came back and then I did the patch compression technique here. So here, again, coming back with a patch with the tacosil and gel foam. And then I put it on top of the inlay graft, inlay patch that I used it. So there it is. And then I did a bit more hemostasis on top. And then that was it. And then the hemostasis. So I'm just going to talk a little bit about dural tear. So you have different factors that causes a dural tear. One is, of course, the technical factors. The other one is the pathological anatomy itself. Technical factors, like you all said, lack of experience. So when you start off, you're trying to have more of these complications than when you experience. You know when and not to intervene in certain instances. The second important is actually poor visibility, which actually causes dural tear. And for me, poor visibility is because maybe is poor hemostasis, but also equally important is the outflow. If you have a good outflow, you have a very good visibility, especially in UBE. And the other one is inadequate triangular approach or inadequate working space that you have for your instruments. You try and push big instruments through a very narrow working space, you tend to have more slipping of your instruments and causing a dural tear. And the other one is, of course, excessive manipulation and, of course, accidents that can happen. With regards to pathological anatomy, is your firm adhesions as well as a redo surgery, which was there on both in this case. So you should be mindful of adhesion, especially even if it's not do a redo surgery. If the stenosis is chronic, you should expect some adhesions to be there. So regarding management of the incidental dural tear, there is this beautiful table. This was actually published in World of Neurosurgery by Professor Harrison Kim and Dr. Wu here. And this table actually depicts, kind of classifies the dural tears into various categories. And in this type 3B onwards, if you look at it, if it is more than 1 centimeter dural tear, if there's incarceration of nerve roots, or if it is a non-linear complex tear, well, then maybe you should consider doing an open repair. But in rest of the cases, probably you can get away with a patch repair technique. But in this case, I used an inlay graft with a tacosil as well. And this is how we kind of classify the various zones. Zone 1 is actually the axilla, and zone 3 is the nerve root, and zone 2 is where the dorsolateral aspect of your dura, and that is where our dural tear had happened. And assessing the size, I use a nerve hook with the horizontal limb is around 1 centimeter. So with that, you can kind of approximate the size of the tear. And there's a patch compression method, which is actually being described in the same neurosurgery journal as well, where you use a patch compression with a tacosil and a gel form. And in addition, they use something like a Duraseal to seal the repair. There are other techniques. You can use vascular clips. You can use endoscopic suturing. Personally, I haven't used it. I'm sure there are even surgeons out here who are using vascular clips with the same portal, or you can use a third portal to hold the edges together, and then you can use a vascular clips. There are people even doing endoscopic suturing. It takes a little bit of effort and some skill, and you can still do an endoscopic suturing. And these are my steps to deal with the insulodural tear. Deal with it early, since you're dealing with water pressure. It can increase the CSF pressure and can cause other complications. So do it early and address it early. Make sure you have a good outflow. It makes your visibility much better. Drop your water pressure to 15 to 20, which is almost similar to the CSF pressure, so that the CSF doesn't, the nerve rootlets have no chance of getting into the dural tear. And have a good meticulous hemostasis. Define the edges of the tear. Once you've done it, identify the type and location according to the table that I have depicted. And then you can use your own various methods of dural repair. You can either use patch compression, suturing, or vascular clips. Or if you feel that it's too complex, you can even convert it to open. And for preventing, for me, outflow is the key for UBE. And it actually helps the visibility much clearer. And then you have I tend to remove the superficial layer first, so that you have much clearer view of your deep layer, and you can slowly separate it out. And if you're doing a piecemeal dissection of the flavum, make sure you use a pen feel, especially in chronic cases, to dissect below and above, and make sure there are no adhesions. And when using ankle tip of your Carison, be parallel as possible and bite what you can see. And if you want to inspect, like in this case, bring your endoscope closer to see what is happening and where is the ligamentum flavum. You can even go underneath the ligamentum flavum and see. You can go underneath dorsal, ventral, and then you can strategize your plan to separate it. So some of the techniques that we have described is written in this chapter where I wrote with Dr. Wu here. And again, I'd like to thank the committee for inviting me, and I hope to see you all around. Thank you so much.
Thank you, Dr. Rajeesh. Now, Professor Wei Bing has finished his operation, so let's welcome him to discuss the application of UBE in cervical surgery. Professor Xu?
Yes, I'm coming. Can you see my PPT?
Yes, Professor Xu.
Okay. Thank you, Professor Hu. Thank you, everyone. I'm Dr. Wei Bing from China, Shanghai Changzhen Orthopaedic Hospital, Spine Department. My topic today is the clinical application and the related anatomy of the cervical laminectomy and the UBE technique in cervical spinal stenosis. We all know cervical laminoplasty is a classic method for cervical spinal stenosis. However, the drawbacks of laminoplasty include significant trauma, detachment of muscle origins, axillary symptom, and poor mutation of cervical mobility. So our question is, for short segment cervical spinal stenosis, is extensive laminoplasty is necessary? So there are some classic papers. This paper is the open cervical laminectomy without fusion for the treatment of multi-segment cervical spondylitic disease, long-term follow-up. The conclusion is simple open laminectomy for the treatment of multi-segment cervical spondylitic myelopathy is feasible, no instability and curves. It means laminectomy for multi-segment cervical spinal disease is feasible, no instability. Those are another classic papers is comparing selective laminectomy and MED with traditional laminoplasty for the treatment of degenerative cervical myelopathy for 2 years follow-up. The conclusion is MED selective laminectomy is traditional cervical decompression and the traditional cervical decompression therapy. So consistent of clinical outcome. However, the group with CMID, MED had better exercise symptoms and quality of life, whereas the laminoplasty group had 2 cases of C5 nerve root syndrome and 1 case of hematoma and a poor cervical room. So we raising a double for short segment cervical spinal disease is intensive laminoplasty is necessary. See, so now UBE is popular in cervical and thoracic, also in lumbar. Let's see some my case. Case 1. The chief component is bilateral lower limb numbness and weakness for 2 years, worsening for 2 months. X-ray, we can see C1, C2 deformity. But no instability and dislocation. From CT and MR, we can see C1, C2 cervical spinal stenosis, deformity, C1, C2 deformity, and the post-arch impression in the posterior area. We can see the spinal cord be compressed. So the final diagnosis is cervical spinal stenosis at C1, C2 level. The surgical method, we choose cervical UBE decompression alone without internal fixation and fusion because this case no instability. This is the UBE decompression alone without fixation and fusion. Post-operative imaging, you can see we decompression completely and preserve the more articular or C1, C2. The bone structure refined decompression and sorry decompression. However, we preserve the bone structure, not need to do internal fixation and fusion. Post-operative CT. So the bone structure be decompression enough and preserve the articular better. So we not need to do pedicle screw fixation. This is a pre-operative and post-operative imaging comparison. So we do MIS for skin incision and neural tissue and bone structure, both be with MIS. Second case is old female, numbness in all limbs, walking unsteady for 8 months, getting exacerbation recently, barely to stand. X-ray, no instability. No instability. And from CT and MRE, we can see C5 and 6, C6 and 7 ligament flavor calcification lead to cervical stenosis. We choose UBE deconversion. We thin and thin cervical lamina along the ligament flavor, and with 2 millimeter calci punch to reject ligament flavor unblock. So we emphasize UBE unblock rejection of ligament flavor. Two-level ligament flavor rejection unblock. Post-operation 3-dimension CT after UBE rejection of ligament flavor. The patient get better after post-operation. The third case is old man walking unsteadily and numbing in upper limb for 5 months. X-ray dynamic, no instability. Pre-operation CT, we can see 2-level cervical spinal stenosis, C5-6 and C6-7, 2-level cervical stenosis. From MR, 2-level spinal stenosis, C5-6 and C6-7. We choose UBE hemilaminectomy. I mean expanded hemilaminectomy. This is post-operative CT. C5, 6, and 7 expanded hemilaminectomy. Post-operative 5 days MRI. We can see we decompensate enough through 2-level hemilaminectomy. Preserve the spinal process. Of course, we preserve the stability. Dynamic X-ray, no instability post-operative. And post-operation 1 month MR. And pre-operation, post-operation 5 days, and post-operation 1 month MR comparison. You can see we decompensate enough for spinal canal stenosis. third case, the patient complained unsteady walking, accompanied by numbness in left hand for 2 years, worsening for over 1 month. X-ray, we can see here is OPLL. Dynamic actually no instability. CT, we can see OPLL in 2 levels, C3 and C4, 2 level OPLL lead to cervical spinal stenosis. Cervical spinal stenosis caused by OPLL. So the final diagnosis is cervical spinal stenosis and cervical OPLL. The treatment is UBE. The first stage, we choose 2-stage operation. First stage is posterior decompression with UBE. And the second operation is anterior approach for ACCF or ACF. 2-stage operation, we decided. First, posterior UBE laminectomy, 2-level laminectomy. We can, from CT, we can see 2-level laminectomy. Peripheral SP tip. From MR post-operation, we can see through UBE decompression, the spinal stenosis decompression enough. Even though we do not do anterior approach decompression, only posterior decompression, the spinal stenosis decompression enough. The patient feels better. So the patient refused to anterior approach decompression anymore. The failed case is a cervical spinal cord injury, cervical central spinal cord syndrome for 3 months. The patient walk normally, but he feels numbness and weakness in both arms, only in upper limb. So X-ray, no instability. And CT show us 3-level cervical spinal stenosis, C3, C4, C4 fail, and C fail 6, 3-level cervical spinal stenosis. And from MR, we can see 3-level stenosis, 3 to 4-level stenosis. We choose the doctor suggests patient do one-side open door laminoplasty, but patient strongly demand MIS technique laminectomy. So we choose posterior UBE cervical laminectomy decompression. C5 totally laminectomy. C3, C4, C6 hemi laminectomy. Post-operation CT. C5 totally laminectomy, and C3, C4, C6 hemi laminectomy. We preserve C5 spinal process tip. Post-operation 3 CT scan. And post-operative MR. We can see 3-level decompression enough, but in lower level, a later compression already still. But the patient clinical symptoms have completely relieved, no any more complaint. Even though there is some imaging compression. X-ray, no instability, even though we do C5 total laminectomy preserve SP tip or hair. So we discuss because UBE laminectomy preserve the posterior tension band and preserve posterior tension band and muscle origin during the UBE laminectomy. For UBE laminectomy, nuclear ligament intact can be preserved. So there is a ligamental flavor interspinal space for the total cervical laminectomy. Here is a natural space for UBE laminectomy, total laminectomy. There is a space. This space serves for the anatomical basis for the total laminectomy of cervical spine and the UBE. So take-home message, cervical laminectomy and UBE must be carefully carried out and on the basis of lumbar technique, which is very skillful. And try to select case suitable for short level laminectomy. UBE cervical laminectomy has the advantage of less trauma, good protection of the paraspinal muscle and the posterior tension band and the facet joint. So this technique has fewer axial symptoms and well-preserved mobility and less C5 radiculopathy. It is an option for treating short or some multi-segment cervical spinal stenosis. Thank you. Okay, Professor Hu.
Thank you, Professor Xu. So we have a question from Dr. Sudhir. If the patient have bilateral symptoms in the lower limb, will hemilaminectomy, cervical hemilaminectomy be able to decompress, as he felt that it may not be as much dural expansion in laminoplasty or laminectomy?
This question is for me.
Yes.
Yes. Yes. Okay. Wait. In the C6 and the C7 level, the spinal canal is relatively large for spinal cord. So in my case, some case, in C6 and the C7 level, I only do expanded hemilaminectomy, not the total laminectomy. After operation, I do some MR. We can see we decompensate enough. Understand?
Yes, Professor Shi, then how would you decide which level to do expanded hemilaminectomy or total laminectomy?
So in my limited knowledge, I think in the lower cervical level, I think expanded hemilaminectomy may be decompensate enough. And in the C3, C4, and C5 level, maybe we should do total laminectomy.
Okay. So the second question is actually open to all of us by Professor Liu. He wanted to ask all of us, if we do not put in a drain, what are the tips and tricks to avoid post-op hematoma and seroma? And if you put in a drain, maybe we answer the first one first. Any tips and tricks? We start with Professor Shi. Any tips and tricks if you don't put in a drain?
Is this question for me?
For all of us, maybe we just have a short answer. Do you put in drain in all your cases?
My case, my UB case now, for cervical case and for thoracic case, I do a drain definitely. For most lumbar case, I also do a drain. I will drain.
Okay, so most of them.
Most case.
Okay, then Professor Song.
Yeah, so I commonly use the drain. Yeah. So can I have?
Yeah.
Sorry, can I have a question? Thank you for your nice lectures. I think in some patients with having severe stenosis case at the anterior and posterior, such as the patient have OPLL combined with the OIL in thoracic and in cervical area. So in such like a patients, when we do the posterior decompressions, at that time the fold shift posteriorly, as there are some possibility to cause compression by the adjacent proximal and distal bony structure such as the lamina. So how do you decide decompression level in such like a patient? Sometimes we do the centripetal posterior decompression for safe decompression. So I just want to know how did you decide the decompression level in such like a patient?
This question is for me.
Yes.
Yeah. So, yes, thank you for your. Thank you. I show my case again. This case is OPLL. OPLL.
Yes.
OPLL. Because the OPLL is, I think, it is, 它是 stable. It is stable. No stable. It's for this case, I suggest patient two-stage operation. First is posterior decompression first, and the second is anterior bridge ACCF. Your question is after I do laminectomy, maybe lead instability.
And then just as a question about when you decompress the posteriorly, so in case in patient with the severe stenotic region anterior and posterior, so when we decompress the posterior first and the cord shift posteriorly, and there are some impingements or some compression in proximal and distal area, especially in the focal regions. How did you, in that case, how did you decompressions?
Very good question. For this case, if we do the decompression if we do the decompression only in this level. Could you see my PPT now?
Yes.
So very good question. If we do the posterior decompression only in this level, maybe lead to secondary impingement in this area. So we show that decompression a little long. But my schedule is two-stage decompression. If there is some decompression not very enough, I do the anterior approach decompression. But my decompression area is very large. So I know your mean. So decompression enough. If we decompression only in this area, maybe your value is correct. Sorry. So posterior decompression widely is better.
Okay, so when you go first is the cervical or thoracic posterior using endoscope, or especially bipolar and unipolar. So we have to pay attention to the such like decompression in patient with needed to centripetal decompression. Some bipolar option could be dangerous in not experienced surgeon. It's not in your experience that you can do that, but I think I just want to comment that.
Okay, good question. So in my calculation, I suggest cervical UB technique master carry out on the basis of lumbar UB technique. I do more than 300 or 500 UB lumbar technique, lumbar, and then I do cervical and thoracic. For my first case, I think my first case. So we do ACDF with naked air or loops or microscope. We all know microscope is better than loops when I do ACDF. But for UBE, it's water-like microscope. So it is very clear than microscope. Understand? So UBE, under the UBE, we see clearly than microscope. So I think UBE is relatively safe than microscope. Professor Wu, please help me.
Yeah, so thank you, Professor Xu. I think the comments are valid. UBE cervical is for more experienced surgeons. Whether we do laminectomy and hemi-laminectomy, actually I've been to many forums and there are expanded hemi-laminectomy is done by several experts. I think they make good analysis and decide the cases of expanded hemi-laminectomy rather than full laminectomy. So I think this discussion is very good, but those are anecdotal cases and needs a lot of experience. I suggest all of us will start with foraminotomy and then ipsilateral laminotomy. For some of the specific cases, then we go to expanded hemilectomy and full laminectomy, then multiple levels. Maybe start with the ossified ligamentum flavum or OYL, then followed by the OPLL, which is more controversial. Then when we are like expert like Professor Xu, then can go to C1, 2. I'm not sure whether we do C0, C1. But anyway, due to limited time, I know Dr. Sudhir has asked a question. We will take that by answering online. We will go to the next speaker, Dr. Nantawat, who will be doing a case presentation for decompression and foraminotomy.
Okay.
Thank you, Professor Shi, also for your wonderful talk. Thank you, Dr. Nantawat. Please start.
Yes. Okay, I will share my slide first. Okay. Oops. Okay. Hello, everyone. I'm Dr. Nantawat Uttamo from Thailand, and thank you for having me and for inviting me, especially Dr. Wu. Today I will present about the case presentation. My case is 63 years old male and a known case of CSMR, the myelopathy and radiculopathy, and status post ACDF C4 to C7 9 months ago. And patient come to see us with the severe pain after operation. The patient feel that everything improved, no weakness, no pain, but 2 months before see us, patient has a symptom come back again with the severe on both arm, left more than right side, and weakness on the left arm. And the past history, patient has hypertension, no food or drug allergy, and no smoking history. And for the physical examination, patient has pain and tenderness at both arm, and no pain on the neck motion, and the motor power grade 5 all except left bicep, left tricep, and both intrinsic hand is grade 4. And spurring test positive on left side, and Hoffman side positive both. And this is the X-ray post-op 9 months. And you can see that there are some subsidence of the case at the C5, 6, and 6, 7. Okay. And this is the MRI. It showed that no any compression at the C4, 5, but in the C5, 6, there are some foraminal stenosis on the left side, and at the C6, 7, there are the foraminal stenosis both sides, but more severe on the left side, and some cervical stenosis, mild cervical stenosis at the C6, 7. And this is the CT scan, and it showed that some fusion on the C4, 5, 5, 6, and some subsidence of C6, 7, and but that there are some fusion. Okay, and this is the CT scan axial view at C4, 5, C5, 6, and C6, 7. Oops, sorry. Okay. Yes. Okay. Diagnosis first.
Can Professor Song, what do you think, and what will you do?
Could you repeat some patient symptom? He had
He has both arm pain, okay, and weakness on the bicep and tricep, grade 4, and intrinsic hand is grade 4, also grade 4 too.
Especially left side.
Yeah, left side more severe, more of tender weakness. No weakness on the right side.
Is there any peripheral lesion as such like brachial plexus or any kind of peripheral peripheral lesion. Did you evaluate the peripheral lesion?
Yeah. We do the EMG, and the EMG show that there are some the peripheral lesion. Yeah, there's a root lesion, right?
I think she had some pseudoarthrosis there, especially in the 5, 6, and 6, 7. Such like pseudoarthrotic symptoms showed some fluctuation symptoms, but I think there are no specific compressive lesion on there. So I don't know what to do, but
okay.
Let me know.
How about Dr. Chayapon, Dr. Haman, Dr. Rajeesh? Any comment?
Can we see the imaging first?
Okay. This one. This is the MRI. And this is the MRI on the left side.
Yeah, I think there's a problem on the foraminal area. There is a stenosis on the C5-6 and C6 and 7, but particularly on the left side. But you said the patient have bilateral symptoms.
Yep.
Bilateral hand intrinsic weakness. Is that pre-op or post-op? Or they are same, just not improving?
After as I asked the patient, the symptom is he has a weakness on the left side before surgery, but after surgery everything is improved. Okay, from a gate 4 to the gate 5, and the symptom, the patient happy period about around 6 or 7 months. Okay, and then the weakness come back again and the pain come back again. Yeah.
Do you have a CT scan?
Yes. Yeah.
I know it's an endoscopic forum, but sometimes it's okay to do open if you all feel so. I'm just, you don't have to always push for endoscopy.
Yeah.
Comments the rest, yeah.
Yeah. For the MRI, it shows that as Dr. Aman comment that there are some stenosis on the foraminal stenosis on the C5-6 and 6-7. Yeah.
I think in this particular cases, I would like to do the injection first to make sure that the symptoms of the patient came from the foraminal area.
Yeah. So let's say if the injection is positive, would you all be what would you all do?
So for me, if the injection is positive, I would only do endoscopic foraminotomy. I think it's suitable for these cases.
How about Dr. Chayapon?
Yes, thank you. Yes, thank you. From MRI, we see very obviously of foraminal stenosis as C5 to C6, C6, 7. However, the patient have on the left side, but the patient have a symptom on the right side as well. So we have to define the symptom on the right side. I would like to ask about the EMG. The EMG. The EMG did show the radiculopathy on the right side.
Yes. They show the right side radiculopathy at the C7. Yeah.
So left side C5, 6, C6, 7, and right side C7. I mean, side also, both sides. Okay.
Right side also.
Oh.
So it's difficult to do because it's obvious in the left at the left side. So I think it's makes sense to do the endoscopic foraminotomy at C56 and C67. But on the right side is from MRI. I think the root on C67 on the right side, the foramen is quite good. So in my opinion, I will done endoscopic foraminotomy on the left side first.
How about Professor Shi and Dr. Rajeesh?
Yeah, sorry. Can I just see the CT scan? Is there any fusion mass at the? You said the cage had subsided, right?
Yeah.
Especially 6-7. So probably the cage subsidence has caused the stenosis. So I think if you just address a foraminotomy, probably you may not address it. So I would actually go for a posterior fusion as well. In addition to the foraminotomy, maybe laminectomy, foraminotomy, and fusion. Considering that the cage is subsided and the fusion hasn't occurred properly open. That's my opinion on that.
Oh, wow, Professor Shi?
This patient only radiculopathy. Okay.
Mm.
One side or both side?
Both sides.
Both sides. But the left side more severe, right?
So I think UBE post-level bilateral PCF.
UBE assisted PCF, you mean?
PCF, bilateral PCF.
For foraminotomy.
Yes, PCF
Okay.
means foraminotomy. Okay.
Okay. For me, I feel from the history when they got better and then it comes back, I like Dr. Rajesh said, I worry about subsidence. And then I have a different opinion. I know I do a lot of scope as well, but I would do a cervical pedicle screw. I would do a foraminotomy both sides, and then I back it with some fusion bone graft. Yeah, this I think because I'm worried about the fusion. I've been looking at a CT scan. Some of the levels really doesn't look like they're fused or fusing. They have some, lytic changes. I'm kind of worried that they may subside further if I do a scope. So I would do a posterior pedicle screw fixation so that I have space for foraminotomy open. And then I will just drill that wide open the foramen both sides and pack in bone graft and fuse it.
Okay. There is a non-fusion. Oh, pedicle screw fixation. It's okay. The conversion and the fusion.
So, Dr. Nantawat, can you show us what you do?
Yes. And this is my diagnosis is depend on the MRI and EMG, and it show the radiculopathy on the at the C45, C56, and CSMR, maybe from C67. And what I do the UBE bilateral decompression and bilateral foraminotomy, and do the at C67 and do the left foraminotomy as C56. Okay, and this is the scope I do. I do the decompression and do the foraminotomy at C67, C lateral, and go to foraminotomy to the contralateral side at the C67 contralateral size, the Pro C7, and then I do the decompression on the foraminotomy on the C56 left side. and this is the post-operative film, and the post-operative MRI. Okay, and this is the post-operative CT scan. Okay, CT scan 6 months. Okay, after posterior decompression, endoscopic decompression. Yeah.
So so we have 6 months follow up for this patient, and it's okay.
This is 6 months after.
And the patient is happy.
Yeah, and actually after decompression, and the weakness is improved from the grade 4 to grade 5, and the pain is gone. Yeah.
Okay.
Yeah, both sides.
Okay.
Pain is gone both sides. Okay.
How about intrinsic muscle weakness after operation? Intrinsic muscle weakness. The patient had some myelopathic symptoms or not?
Before. Yeah. Before.
Okay.
Yeah.
Well, actually, the MRI don't show much central compression. Dr. Nantawat, what makes you feel that you need to do central decompression? This looks quite okay. Maybe, okay, maybe one little bit touching on the cord, but not too bad. So what makes you feel that you need to do laminectomy more of the level? I mean, or bilateral decompression?
Yeah. Actually, that because I'm as you said that is the patient has a problem maybe as from the subsidence of the case, right? And actually that I'm afraid that in the future is maybe more collapse as you mentioned, and so I think I need to make a more room space for the cord.
Actually, I was looking at the screws. They are really short. The cage doesn't look like holding. So I think we really need to watch this patient for a while. Sorry, Dr. Nantawat. I find this case very fascinating. Yeah.
And as you mentioned that, and another point is, I think if we do the bilateral foraminotomy decompression, I think if we to make sure that everything is okay, I think decompression, the central decompression can make more the good view for do the contralateral foraminotomy.
Okay, I just want some comments. So I think the main cause of such like radiculopathy, I think in these patients, I think pseudoarthrosis. So it could be one of the aggravating factors to factor of radiculopathy.
Yes.
And so full decompression, wide decompression could be okay. So, but I think some fusion surgeries more, I think is better. And I want to just comment the C7 about the C7 nerve root. The C7 is some myotome showed some triceps or the pronator of forearm, but sometimes it's related with the finger extension. So it could be one of you felt one of the reasons you felt some intrinsic muscle weakness. It's sometimes C7 is a cause of some finger extensor. So maybe the patient has only radiculopathic symptom, some myelopathic symptoms. So.
Yeah, thank you, Dr. Song.
Okay, so due to limited time, we move on to Dr. Harman.
Yep.
Dr. Harman will be showing how we do in the pathology.
Yeah, thank you, Dr. Wu.
Thank you so much.
Can you see my slide?
Yes, we can.
Yeah, okay. Good afternoon, everyone. Thank you for having me for the committee. So today I would like to share a case that is maybe commonly overlooked by us. So this patient is male, 41-year-old, with non-specific back pain, especially on his right buttock pain, no radicular pain. For physical examination, we only find a local tenderness just cranial to the PSIS with no specific provocation test. On the MRI, there's no marked disc pathology or foraminal lumbar pathology. It has been conservative treatment by means of medicine and physical rehab, but no improvement. And on the CT scan, you can see the enlargement of the right transverse process of L5, docking to the sacral ala, indicating the lumbosacral transitional vertebrae. And as you can see, the Castelfi classification is 1A. So it is a Bertholdt syndrome. It is a congenital lumbosacral transitional vertebrae. So usually the normal gap or the transverse process to sacral ala is between 2 until 3 cms. But in this case is very narrow with the clinical symptoms. It could be lower back pain or with a leg pain, but in this case it's only a lower back pain. But we have to consider the differential diagnosis with SI joint pain, hip pain, and etc. So for this patient, I would like to ask how will you establish the diagnosis, and if it is through Bertholdt syndrome, what will you do for the option of the treatment?
Yeah, maybe we start with Dr. Chayapon.
Thank you very much. This case is Bertholdt syndrome that we see in the CT scan. Have enlargement of the transverse process of the L5, and we see some like the pseudotosis of the L5 and around the sacrum. So this syndrome can make the back pain, and sometimes can make the L5 root compression. In this patient, he have a symptom like a buttock pain. So I think the buttock pain can come from the nerve root compression, especially L4 or L5 nerve root. So in this case, I will do endoscopic decompression to decompression the L5 nerve root.
I mean, how are you sure enough that the symptoms of the patient came from the Bertholdt?
Okay, thank you very much. Actually, the back pain and buttock pain can come from many causes, and to confirm the first thing I would make the injection at the pseudotosis of the between the transverse process and around the sacrum first. If the patient feel better, maybe come from the pain generator, maybe come from this lesion, and so I think doing endoscope decompression maybe make the patient better.
How about Dr. Shi and Dr. Song, Dr. Rajeesh, Nantawat? Maybe Dr. Shi first. Any question? Any comment?
Professor Wu, no question. No question.
Okay. Dr. Song, any comments? How would you treat this? I cannot hear you. Maybe on the mic.
Did you try to the pain source of some gluteal area pain? It could be originated from the SI joint or any kinds of steps. Did you inject any SI joint injection or?
Yeah, I mean, yeah, it is important for us to establish where's the source of pain, right, Professor? So in this patient, I suspected the pain is come from the vertility, so I only inject the pseudoarthrosis. I don't inject the SI joint.
Okay.
About Dr. Rajeesh and Dr. Nantawat?
Okay, personally, I don't have much experience, but I've assisted a few cases with Dr. Wu. Yeah, you're right. First is to establish the source of pain. So you inject first, or maybe a radiofrequency ablation second, because these are very rare cases to do. And if that is confirmed to be the cause, then as we did for our cases, we did endoscopic the zoonoarthrosis resection. We assisted in a couple of cases, and patient had pretty good relief of the pain. Yeah.
So it's interesting. You say the radio frequency. Which location will you do? Will you deliver the radio frequency?
It's at the L. So it's a 4-5 and the level below. So top and bottom, facetal joint. So basically at the facetal area. Yeah.
Dr. Nantawat?
Oh, I think same as Dr. Rajeesh. So I will do the injection first to check that where is the pain generator come from. Okay.
In my experience, limited experience, I mean, after all, although this is fairly common, but I find that there are two groups of patients having it. It's quite interesting that Dr. Harman showed us this patient is at 40. I find that there are two groups. First group is actually younger, about 20 to 30, or 18 to 30, when they have a lot of physical rotational activities or flexion extension. Then they find a very unique spot pain right at the pathology area. And then you do all the SI joint stress tests, they are not painful, and the facet joints are all pretty look normal. They haven't had slip this yet because it's quite early. So I think the diagnosis by block at the area, and if it's possible, and if it shows relief, then when the pain comes back, we do a resection. Second group of patients, which I see more commonly at around 40 to 50 years old, is when they have also, besides this long duration of buttock pain on and off, they may have a slip disc in the L4-5. This group of patients, if the slip disc is significant, for conservative treatment, I do the slip disc by endoscopy, and then I also release the pathology anyway, because it's just like an added service. Of course, with the full consent of the patient, noted a little bit more risk on the L5. So these are my thoughts. I've done a number of these cases, but I'm not sure whether any one of us can say we are experts. I mean, how many pathology do we do? I mean, Harman, maybe you show us your expert opinion and what you do.
Yeah, so as you mentioned, the most important thing is diagnosis. So I do injection first in the pseudoarthrosis, just put a lidocaine and see whether the pain resolve or not. If it is positive, then I do endoscopic resection of the pseudoarthrosis. But what I do experience both using uniportal and then biportal, but I more favor to biportal. So if the symptoms only have buttock pain, you can do whether approach from the ipsilateral or the contralateral you're familiar with is okay. But if the patient also develop L5 nerve root leg pain, I recommend you to do from ipsilateral approach, because it's easier to assess the L5 nerve root from the ipsilateral approach. So I just do a resection of the pseudoarthrosis, but the thing that I found the difficult is to see the line. So you have to take your time to identify the pseudoarthrosis. Maybe you can do a fluoroscopy to check your docking site, because using biportal is commonly to misplace the docking site. So I recommend you to check frequently with the fluoroscopy. But once you find the pseudoarthrosis, quite easy. You just follow the pseudoarthrosis from the medial into the lateral aspect of the pathology. And if you needed to decompress the L5 nerve root, is easy. You can see here there's a L5 nerve root. And another question is how much resection that we need to ensure the pain resolved. So from the article, 7 until 10 millimeter gap resection is quite enough for the pathology. That's what I do.
Yeah, I use the drill 4 mm drill, so it's for me. I also use that to measure about at least 8 mm gap. I added an O-arm spin usually intra-op to make sure I don't miss out the pathology. Make sure it's a full resection. There are times when I do uniportal scope, and then after I O-arm spin, I still realize there's some bone left, so I just drill one more time and then spin one more time. I feel quite sad. The patient have 2 CT scans, but I suppose it's better than a left alone pathology. So yeah, very good cases. I think very interesting. Any further comments? You have more slides, Harman?
No, I'm finished.
Okay. So anyone have any more comments? Any audience have questions? All right, I think we finished right on time, about 5:30 now. I thank all the speakers. I thank Professor Liu and all the APSS members who attended the session. I think this is a very interesting seminar. We have really diverse cases, ranging from top to bottom, ranging from also controversial cases, which make it very interesting discussion. I really thank all the case presenters. They really bring very, very good cases and interesting cases to us. And a very fruitful afternoon.
Yeah. Thank you all.
Thank you.
Thank you so much.
Professor Liu, you want to summarize?
Thank you very much.
Yeah. Okay. So it's a Sunday. I think all of us should go to our family with learning all the good cases, and I wish you all the best, and see you all in the upcoming APSS meeting. Lawyer, you have any comment? You just put on your video.
No comments.
Okay.
I think you can just tell about the next webinars.
Okay, so we'll be having a next webinar. I think the next one will be on basic spine. So our program will be up soon, and then we'll be putting out our posters. Will be, I think, held in October 20th for the APSS Scientific Online Webinar. It's a collaboration exclusively with CSRS AP Chinese chapter. And on the 27th October, also we will have another, so in 1 week apart, we also have one basic science webinar series. So October will be a busy month. I hope all of us will be able to attend this. And I wish all of you the best in your practice, as well as have a good Sunday and weekend. Thank you very much, everyone.
Thank you very much.
Thank you.
Goodbye.